Hi, I'm Howard Gilmer, Director of Amputee Rehabilitation at Medstar National Rehabilitation Hospital, talking to you today about pain management in amputees. First of all, the biggest thing to talk about is phantom pain. This is something everyone's going to get, especially right after surgery. The pain is usually in the amputated limb, and it's described as usually a burning, shooting, stabbing, or a freezing type pain, period. It can be described other ways as people use their imagination to describe their sensations, period. But it is the most common after amputation. For phantom sensation, it's a sensation of the limb still being present. It may also be described as tingling, itching, or cramping most commonly, period. However, this is not unpleasant. It's not painful. It's not the pain that keeps you up all night and the one that keeps you from going throughout your day, period. This usually is normal and resolves usually in time, period. All right, for phantom pain, we need to talk about phantom limb pain versus residual limb pain. Remember, the phantom pain is at the site of the previous limb, and it's not localized to distal residual limb. However, residual limb pain is the pain most often associated with the surgery, period. So it is at the residual limb in the area that does still exist. It may be complicated by a neuroma and also an infection. So watching for signs of infection such as discharge are very important things to do, period. Residual limb pain is also normal post-operatively and may involve the incision. So if you see the sutures or staples coming apart or drainage through those, it's something that you need to consider as infection being the cause of your residual limb pain. Okay, so phantom limb pain is experienced in about 50 to 80% of amputees, period. I think it's even more than that. I think it's closer to 100, however. Phantom sensation is always greater than 80%, but also almost always goes away pretty consistently, period. More common in adults, period. And it's not only in amputees, it's also common in strokes and spinal cord injuries, period. There is an increase with phantom limb pain if you had a pre-existing condition that causes pain, such as peripheral vascular disease, period. Etiology of phantom limb pain is still basically unknown. They do have a lot of theories, however. It is seen in spinal cord and congenital limb deficiencies also, so there is a brain component to this. It's not just your limb, period. Okay. Also, at one time before modern medicine, it was thought to be psychogenic, meaning it's all in your head, but we know now that that's not true, that this is a cause of the amputation itself. Period. Okay, on this slide, we have a picture of the homunculus. And the reason I show this is because your brain has areas that are responsible for sensation to every part of your body. And when your arm or your leg is amputated, the part of the brain that's responsible for that limb is still there and still wonders what happened to the residual limb. There is a remodeling which can be shown on MRI, but one day in the future, hopefully we can do something to help the brain adjust and adapt to this amputation. But for now, we are still left with this being, I think, the cause of most phantom pain. Okay, for phantom pain risks, it's adults more than children. If you have phantom sensation, it may increase phantom pain. If you have an improper fitting prosthesis, and this is important, your prosthesis fit may be a cause of your pain in your limb, period. Also, here at NIH, we like to use shrinker socks, which seems to severely and significantly decrease your phantom pain and phantom sensations also, period. Also, you need to consider lack of prevention. So not wearing your shrinkers, or if you don't want to touch your limb, you tend to have more of a psychological component. So touching your limb and observing your limb, observing dressing changes, and massaging and touching your limb will help with your pain, period. Bilateral amputations are worse. Shorter residual limbs are worse. Lower limb amputations causes more phantom pain. And there's also social and psychological stressors. So it's, the economy and the infections and the COVID infections, are stressors. Outside forces can increase your phantom pain and phantom sensation. All right, differential diagnosis. For phantom pain or limb pain, you have to consider number one, infection. And right after surgery, you may not know that you have an infection. It may take weeks to months to even find out. We've had infections maybe even almost a year after the initial amputation period. Another thing is a hematoma, which is a collection of blood and fluid under the incision, which can cause a lot of drainage. It does not mean it's infected, but there is fluid which would cause drainage, period. Also edema, and a lot of people were edematous prior to surgery, so it's something you have to manage. You can either medically or with compressions. Another issue are DVTs, which is actually very common and should be tested for if there's any sign of a significant edema, which doesn't equal the pain that you're having, period. Another issue that you may not notice initially after surgery is heterotrophic ossification, which is an abnormal bone growth around the amputation site. And as that bone matures and hardens, it can become an issue. And also, finally, the neuroma. Neuroma is usually seen about 6 months to a year initially after the initial surgery. It's a result of the nerve continuing to grow, causing pain with compression of the socket and actually everyday usage of your limb in the socket, such as walking, transferring, even sitting. And as the neuroma grows, so does your side effects and pain levels, period. All right, neuroma. Here's a picture of a neuroma. As you can see, it kind of looks like a Q-tip at the end. That part of the nerve is the one that needs to now be resected. There are new procedures out there. We send a lot of people back to Georgetown and Washington Hospital Center, who are our referring facilities, where they do nerve resection, also called TMR, which stands for Targeted Muscle Reinnervation Surgeries, period. I just had a patient today who we had to send for this procedure because that surgery wasn't done at the time of the amputation. All right. So as you can see on this slide, we have what the definition of a neuroma, which is a normal occurrence. The nerve is looking for somewhere to go. It doesn't have a target, so it continues to grow out, causing that bulge shape. The pain is usually a nerve type pain, same as you might have right after surgery, but continues to worsen over time. And as a nerve pain, it's sharp, burning, or electrical, period. And once again, it can happen months to years even after the amputation. All right, treatment. Right after surgery, we like to use something called Neurontin. It used to initially be used as a anti-seizure medication, but in lower doses, we learned that it works very well in controlling neuroma pain, period. Lyrica is basically the precursor for Neurontin, so they both work about equally. We also like to use some types of old antidepressants. These are called tricyclic antidepressants, such as Elavil and Pamelor. We use these mostly at night because of the side effects. They are not an antidepressant at this dosage. They are strictly for nerve pain relief. We use them at night because of the sedation that they cause, and they can help you sleep throughout the night with these neuromas, period. Okay, opioids right after surgery is usually a must, especially the first few weeks. So we tend to use oxycodone, any type of morphine derivative initially. This is not a long-term solution to your pain. This is strictly post-operative. We like to have patients off of this medication at least a month after the initial surgery, period. There are other medications like baclofen, ketamine, calcium channel blockers. I really rarely use those. We tend to stick with the ones I've mentioned above with very good results. Also, non-invasive treatments such as massaging, touching, rubbing your residual limb will help with pain. Passive and active range of motion also helps. Here at NRH, we're going to start using TENS units, which is like an electrical stim that kind of overworks the nerve and kind of calms the pain down. Acupuncture is also something that could be used. We also have mirror box therapy here that we tend to use. It doesn't have the same effect in everyone, but it is somewhat effective in everyone. Also, the most important thing that we'll start, especially right after surgery, are the shrinker socks. These cause desensitization, and also we encourage, once again, the tapping, the rubbing, the constant contact, and these shrinkers do cause that. It's important that you are fitted correctly for these, as these tend to stretch out over time, so you may need to update to a new pair after a few weeks of using the same ones, period. Also, we use biofeedback, cognitive feedback. We also have psychology come and talk to you, since limb loss is a major event in your life, and we find that very productive. All right. Also, sometimes we need to use a steroid injection. This is usually to diagnose a neuroma. We have had patients come in with spinal cord stimulators, but that requires a pain management consult, and dorsal root blocks also, but we usually send those out for pain management consultations also. These are very rare that we have to go this far and this aggressive in the treatment of pain, but it is also an option. Finally, going back to the neuromas, if you did not have that surgery at the time of your amputation, it is something to consider in the future if you develop a neuroma and the neuroma symptoms here. Also, sometimes people also have limb revision secondary to possible infection of the initial amputation, and that may require another nerve resection and TMR. But mostly we want to look for obvious signs of infection. Next slide, it shows mirror box therapy. Basically, you put a mirror between the amputated leg or arm and the non-amputated limb, and it basically shows your brain seeing both limbs. It does work in every person that you tried this, it just doesn't have the same effect in everyone. It's 15 minutes a day if you're having symptoms, and it works fairly well. And it's also something you could do at home. Once you get home and just purchase a $5 mirror and a long mirror if it's a leg, and it works very well. We do studies on this, and it shows under an MRI that the brain does show the different signals with the mirror box in place. Next, we have virtual reality. We are starting to use that here in NRH. Basically, with the goggles, it's not much different from mirror therapy. It's still using the same pathways to treat your phantom pain or limb pain. So take-home facts. Phantom limb and phantom sensation is common. At least 80% of patients get phantom pain. You need to differentiate phantom pain from phantom sensation. So the basic question would be, does it hurt? Is it uncomfortable or does it hurt? And if it doesn't hurt and it's just a little bothersome, we just consider that phantom sensations, which usually go away. Just be aware of the differential diagnosis such as infection and neuromas. Also, sometimes we'll even use other diagnostics such as an EMG. Also, you need to check your neurological status and your vascular systems, because a lot of patients have problems with their circulation, and that is something you want to check consistently. But take-home facts to finish this off with, I like to say, minimize your stressors as much as you can. If you need psychology, we have psychology available, and your doctor and your surgeon should also be able to find a resource for you. Desensitization is very important, touching, feeling, rubbing, and in some cases, wanting to look at your limb, especially right after surgery. Always start non-invasive and use pharmacology if needed. Always try to stay minimally invasive and then consider surgery when all of those fail. There is no best method for treating pain. You just have to do what works for you. Thank you.
Okay. Again, I wanted to thank Dr. Gilmer for recording that lecture. And if he's watching, I apologize. I tried to edit out the periods, couldn't, and I actually thought it was kind of funny to leave it in to show that even the physicians are kind of human and get nervous. So the section I want to try to talk a little bit about is just reinforcing some of the things that he talked about, being the big one is that pain is pain no matter what it's generated from, whether it's phantom pain, meaning pain in your missing limb, or it's pain in your residual limb, in your stump. Pain can be something in the upper, and especially in the upper limb population, but also quite a bit lower. And depending on the studies, anywhere between 10 and up to 76% people have residual limb pain, meaning pain in their limb. And about 85% of the people have phantom limb pain. When you have that, prosthetics really isn't the big factor. It's, you know, if you're in pain day in, day out, life itself is difficult, and you're doing things, just getting out with your friends, playing with your kids, all that becomes difficult. So trying to address the issue with the pain just makes life in general better. Unfortunately, what you saw in a lot of the different slides from Dr. Gilmer was that when there's lots of different modalities, lots of different treatments, lots of different medications, that means not one of them works perfect. It's not the end all be all. So you really have to try different things and see what works for you, just like different drugs affect people's bodies differently. The different things, some of the different treatments are great for people, and other ones they don't get as much results from. One of the big things I think process need to do, and the MDs also, is to listen to you guys, to really find out and kind of dig deep to figure out what the pain is generating from. So it's kind of keeping good notes on yourself, meaning, do you get the pain in the evening? Do you get it after you've had certain foods? Do you get it when there's higher stressors going on in life? What things help kind of takes the pain away? And then we can kind of dig down to try to find out if we can figure out what the root cause is, hopefully there's a better treatment for it. Part of that is just telling out, a lot of it's normal. So things like phantom sensation. Every person that's had an amputation is going to have phantom sensation, meaning they could wiggle their fingers, their foot might itch. But then the question is, well, is that painful, or is it just you can feel it? Most people, when the injury first happens or the surgery first happens, they don't tell anybody about the weird sensations and pain, because they're going to think the person is going to think that they're crazy. Like, why does my foot hurt if I don't have a foot? And they don't want to talk about it, or they just want to say that they have a high pain tolerance and just think that they have to put up with it. So the first thing we try to tease out is it, again, phantom sensation, meaning you can move it and you feel it, or is it phantom pain, meaning it's pain in the missing limb? Now, when it's sensation, it sort of makes sense, and there's some really kind of interesting, weird things that happen in the brain when we've had an injury like that. A lot of people will report that, let's say it's an upper limb injury, they'll report that right after surgery, their hand is right where the anatomical hand would be. And then over time, their hand starts to kind of move up until eventually it's on the end of their limb. And that's kind of what we call cortical reorganization. What that means is that homunculus that Dr. Gilmer put up, that kind of that funny picture of the guy with the big hands and the big face, that's representing how much of the brain is dedicated for things like our hands, our legs, our face. And when you have an amputation, you don't have sensation and you don't have the motor control for it. But the brain still has this area that's dedicated to control it. And the brain doesn't know how, sometimes gets confused, because what my eyes are telling me that I shouldn't feel my fingers, but my brain is telling me all those nerves that go from my brain down into my hand are still there. And the two don't match. And the brain can sometimes sense that as something's wrong, and it represents it as pain. 100 years ago, we just thought, it's kind of like in your head. It's not real pain. Real pain is pain no matter what. And now we know with MRIs of the brain, those areas are still lit up. The part where you can move your fingers, you can wiggle your toes, it's still there. It just doesn't have the same connections with a traditional surgery. And the brain tries to reorganize, and that's why that limb sort of moves up your arm over time. One of the other things is, again, those nerves that went down to my hand are still in my arm. So in a traditional surgery, and it sounds a little morbid, but they simply take the nerve, pull it out, cut it under tension so that it pulls back up and it goes in deeper. And they hope that it doesn't grow out close to the skin. But that same nerve that went to my hand is still there. That's why sometimes you can touch a spot on your arm and get a sensation in your hand. So if you have swelling, which is like if my arm and my leg's hanging, gravity's going to pull the blood down and my limb's going to swell. And no matter how much I try to tighten the muscles, it's not the same as standing up and walking or contracting the muscles through full range of motion. So you get swelling. And if there's swelling in my limb, it's squeezing the nerve. And that's exactly the same sensation as someone squeezing my hand. That's why we use those shrinker socks quite a bit, is to try to push that fluid up and out. The shrinker socks should never be uncomfortable or painful. They should feel tight, because it has to be tight enough to push the fluid back up so that you get good kind of blood flow into the area and push the edema and swelling up. And then differentiating the difference between the sensation and the pain is if it hurts, and that can be the throbbing, the dull ache. And there's lots of studies on mirror therapy, but kind of the condensed version of why we think it works is that idea that if I, like the picture Dr. Gilmer had, or the one here, where if I have a mirror in between my legs and I'm looking at my amputated leg, I see my other one. So they match. So now what my brain feels and what my eyes are seeing match. And if you're, let's say, for instance, it feels like your hand is in a cramped position, and all day long, in your mind's eye, your hand is in a cramped position, you're going to fatigue. You're going to get this dull ache in your arm. So if I put a mirror in front of me and I put my anatomic hand so that I'm looking in it and the two match, they're both in a cramped position, if in my mind's eye I can start to relax my physical hand and imagine relaxing my amputated hand, and I'm seeing it, a lot of times people can actually get to where they can open up their hand and they can move their fingers or they can move their wrist. And now that cuts down on that tension that's in your mind. And that helps with that dull sort of ache and cramping. And some of the really neat things they're working on right now are things like virtual reality, actually putting goggles on. And then when I look down at my amputated limb, I see my own arm, or I see a prosthesis, and I can move it around in space. And I could actually test different prosthetics in virtual reality by thinking open and close and moving my arm around. And it's almost that thing, I had one of the physicians explain it to me, almost like seasickness. I'm in a boat, I'm moving up and down the waves. If I look at the floor, my eyes are telling me I'm not moving, my inner ear is telling me I'm moving. The two don't match, and I throw up. That's one of the theories that they think phantom pain is what your eyes are seeing and what your brain's feeling don't match. And instead of throwing up, it represents itself as pain. So it's trying to get the two things to match. And that's why some people have relief wearing a prosthesis, because they look down and they have now a limb there, they have a foot, they have a hand, and the two things match. Like Dr. Gilmer said, there's lots of different therapies, from mirror to massage to desensitizing. The big thing is a lot of these non-invasive modalities are easy things to try. And if it helps with the pain, fantastic. If it doesn't, you try another kind of non-invasive thing to try to see to help that pain. The drug regimens, there's lots of different medications, from antidepressants to things like gabapentin, that's an anti-seizure medication that just kind of slows down that influx of impulses to your brain to give your body a chance to kind of slow down from this big injury. An amputation, whether it be from a trauma or a dysvascular, is a huge insult to the body. It's a huge trauma. And sometimes just slowing down those impulses for a bit to give your body a chance to heal will help. One of the areas that I want to talk about here, a good section at the end, is targeted muscle renovation and RPNI. I've been doing this now for a little bit over 25 years, and I've seen a big difference the last 5-10 years with having a surgical option instead of just the different modalities. And then residual limb pain is the one that the process myself is probably involved a lot in, and that's trying to figure out, is the pain in your limb, is it caused from a medical problem, or is it caused from the prosthesis? So where we try to dig it out is, does my limb hurt even when I'm not wearing the prosthesis, or does it get worse or just come about only when I'm wearing it? And that kind of dictates, if it's a medical problem, we get you to the MD to talk about what the root cause is. If it's prosthetic, it's usually friction or pressure. The way to tell the difference in that is, friction is kind of like wearing a loose shoe. Your prosthesis is loose and it's sliding, and you get a blister, like that shoe riding up in the back. The way you adjust it with a shoe is you put a thicker sock on. So if you have a pair of loose boots, you go from a thin sock, dress sock, to a wool sock, and it tightens the fit up. In a prosthesis, we just put a thicker sock on. They come in 1 ply, 3 plies, and 5 plies, different thicknesses. And if you're a person who has a lot of fluctuating edema, a lot of swelling, meaning like if you eat a little bit of salt, you swell, you're going to fluctuate from day to day. And you have to kind of adjust the number of socks, not only day to day, but from morning to afternoon. If I took an ACE wrap and wrapped it around my upper arm and came back 15 minutes later and took it off, I'm going to be smaller in that area. Well, if I take my limb and I put it in a prosthesis and I stand up and I'm a 200-pound guy and I'm putting 200 pounds of pressure through my limb, I'm going to push that fluid out, which means I'm going to sink in deeper. The way to stop that is to stop what I'm doing, put a sock on, check the fit to make sure that I'm seated in that prosthesis correctly. And then the other is pressure, just meaning an area is just too tight. Like again, kind of that idea with a shoe is a tight-fitting shoe. You're getting some pressure over that bunion, or the width of your foot is wider than that shoe design, where we have to kind of stretch the shoe. We do the same thing with the prosthesis. We sort of stretch the prosthesis a little bit to make room for it without making it too loose, where we're getting friction. If it's medical, then the physician gets involved to try to figure out what the root cause is. Is it infection? Is it poor blood supply back? Is there some bony changes? Now, the part that I think has been kind of interesting the last few years is this idea of targeted muscle renovation. So in a typical surgery, like I said earlier, is you're typically pulling the nerve down, cutting it, and letting it retract. The thing is, the healthier you are, the more the body wants to heal itself. And that cut nerve wants to regrow. So it tries to grow back out to find a muscle, because that's what it's meant to do. And if it grows out close to your skin, that's where when you get that thing where when you tap a spot, all of a sudden you get that shooting pain. That means that nerve, that neuroma has grown kind of close to the skin. Also, what happens is when you cut the nerve, there's this coating over top that kind of tells it where to grow back to. If it's cut completely, instead of growing out into a nice stream, it grows into a big ball. And there's no cut end, so it's almost like a leaky pipe, or like kind of a live wire sitting inside your arm or leg. And that's where you can get kind of the weird things of the burning sensation, or just you don't have any pain at all. All of a sudden, you just get this shooting pain that can drop you to your knees. And that's because the nerve is firing when it shouldn't, because it's not connected to anything. And what's kind of neat is so actually, what is TMR? What it stands for is targeted muscle renovation. It's kind of a fancy word for just meaning we're taking one nerve and moving it into another, or the surgeon is taking one nerve, moving it into another muscle so that it's happy. So for an example of like an upper limb, because that's when it was first, let me back. When it was first done was in 2002, and it was meant to get better prosthetic control. They weren't even thinking about pain. It was just trying to get a more sophisticated prosthesis by getting more inputs. So that way, in an example like a transhumeral, the nerves that went to my hand are still there, but again, they were cut. So I could think open and close hand, but nothing would contract because I only had my bicep and my tricep. Everything else was just cut. So they had this idea that said, well, what if we take this nerve that went to your median nerve, that went to your hand close, and we put it in a different muscle? Now, when I think hand close, a portion of my bicep contracts, and we can put an electrode over there. So now, instead of thinking flex arm, tighten bicep to make the hand close, you could think close hand and the prosthetic hand closed. And they did the first surgery was actually on a gentleman that was bilateral shoulder dysarticulation, and they did it in his pec muscle. So when he thought hand close, hand open, elbow flex, elbow extend, different parts of his pec contracted. And we could put a sensor over so he could think open hand, and it opened. But what was kind of neat was they started questioning people, and they came back and they started giving them different measures. And all of a sudden people were saying, well, I can kind of use the prosthesis a little bit better, but you know what? I don't have that burning sensation anymore. I don't have as much pain. Now, it didn't take all of it away, but it knocked it down quite a bit. And they just kind of said, well, that's great, but how are you doing with the prosthesis? Because that's what they were really focused on, was the prosthetic function. And then as they kept doing more and more surgeries, they kept getting reports of less and less pain, less neuroma, that shooting pain, and less phantom pain. Because again, now the nerve is doing what it's supposed to do. You think tighten hand, and there's a muscle contracting. Now, the little difference between targeted muscle reinnervation and RPNI is targeted muscle reinnervation uses surface muscle because that's where we're putting the electrodes. RPNI, they take the nerve, they put a little small 1 centimeter piece of muscle over top of it and bury it deep in the muscle. So now when I think hand open and close, or move my foot up and down, a little muscle contracts deep inside. And the nerve is now happy. It's doing what it's meant to do, and it doesn't want to grow out close to the skin. It doesn't want to grow into a big ball. And when in my mind, when I think contract, or I think move my leg, a muscle contracts. So it feels more natural, and you don't get that dissociation like we talked about with the mirror therapy. So the thing was, this was a huge deal, because now it wasn't just taking a person and making them a better prosthetic user, by 10%. It was taking someone that was in excruciating pain and knocking it down a couple notches, taking someone that their hand or their foot was constantly burning and lessening it. And that was for a first published study was in 2014. And they had been doing TMR since around 2002. But where it really started to pick up is when they started publishing literature that was about pain, because that's a huge issue. Again, if you're in pain, life itself is difficult. You're arguing with your kids more. You're not enjoying your friends. If you're a better prosthetic user, it's kind of a feather in the hat of the prosthetist or the surgeon. But the big thing is really the pain management. And then they came out and did another study that looked at kind of normal treatment. So let's say before this surgery back in the 90s, I came into my surgeon and I said I had pain in my arm, and they tapped and they found a neuroma. And they said, okay, what we're going to do is we're going to pull that nerve out again, cut it, and hope it retracts and doesn't grow out. But it did it the first time. So odds are it's going to do it again. And then we started coming up with all kinds of different things to try. Try taking the nerve and burying it into the end of the bone. Try taking two nerves and sewing them to each other. And then none of them worked real good again. So in this next study they did, they took a group of people and said, okay, one group of surgeons is going to do targeted muscle renovation. The other group of surgeons for this revision are going to do whatever they want to do, bury it in the bone, suture to each other, cut it shorter. And we're going to look at how much pain they have afterwards. And I'm going to throw a bunch of statistics out because I kind of like statistics. I don't want someone to tell me I'm going to get a little bit better or this drug treatment might work. I want to kind of know how it worked for a big group of people. And in the people that had this targeted TMR surgery, phantom pain, the pain in that missing limb, decreased 2.3 compared to 0.2. And it's not percentages, that's on a scale reduction. So that's a huge difference. People with residual limb pain in their limb, that shooting neuroma pain, it decreased by 2.9 compared to 0.9. That's almost a 3-time, or it's more than a 3-time decrease. And then a year and a half out from surgery, there was a decrease in phantom limb pain of 3.6 versus 0.5 for the standard treatments. And that's someone who underwent revision surgery, just not targeted muscle renovation. And then the same thing, the decrease in residual limb pain was huge. And then there was another study that was done afterwards to say, well, this was for revision surgery, helped with it. But what about at the time of injury? So I'm in a car, I leave here right now, God forbid, I'm in a car wreck. And I go to a center that's doing targeted muscle renovation, they take me to. Can we do targeted muscle renovation at the time, or RPNI at the time of surgery, versus not doing it at all, doing it later? and they took this group and looked at them. And there were TMR associated was a 3 times higher odds of decreasing phantom limb pain and a 4 times greater odds of decreasing residual limb pain, which is, again, huge. And ignore the part that maybe it makes you a better prosthetic user or that some of these future prosthetics will be able to take advantage of it. Real life right now was that I had a decrease in pain. And it's pretty impressive that during the study, I talked to a couple of the surgeons that were involved in this study, and halfway through the study, they ended up stopping the study because they deemed it unethical to not do targeted muscle renovation if you had an option of doing it, which is pretty impressive. It'd be like taking a cancer treatment and you got one group of people that's receiving a drug and they're getting better, and another group that's not receiving the drug and they're not getting better, and saying we're going to continue this study because we want to get to the end of it. Here they actually stopped the study and said, guys, our best treatment right now is to do something with this nerve, whether it be the RPNI or the TMR. And then I'm trying to leave a little time for questions because I'm sure there's lots of questions out here. One of the ones that seems to always come up is, how far out could you have a revision, and will it help with the pain? There's not great studies on that right now to be able to quote statistics like I did in some of the other ones. What I've seen just anecdotally is that the farther out you go, the less dramatic the change is. Meaning that if I've been in pain for 15 years and I come back and have targeted muscle renovation, I might get a little bit better, but it's kind of a weird thing. It's almost like that pain is frozen. It became my norm for 15 years. And I'm not going to get a major change. It's kind of like when someone has back pain and they've been in pain for years and years and years, and then they have a back surgery that is meant to decrease that pain. They're still left with some, and they don't really know why. They don't know whether it's imprinted in the brain that it becomes your norm. The sooner either time of amputation had the most effect, and then the closer has the more effect. But I have seen people 5-10 years out that have told me they've had a decrease in pain. I'm going to try to switch over. Hopefully I don't lose you guys to some of the questions here. Let's see. Let me just read them. I am wondering if there are results yet from studies of freezing nerve endings to treat phantom pain. I've seen some of the studies. I can quote the statistics to you off the top of my head. The difference between a lot of the surgical treatments and the TMR and RPNI is that, things like at one point they used to inject the nerve with phenol or another substance to try to deaden the nerve, or do a local or even Botox for a couple months, like calm the nerve down. But then the nerve wants to come back and grow and do what it's meant to do, which is contract a muscle. And that's what I think is kind of so unique about this idea is you're putting the muscle back, or the nerve back to doing what it's meant to do. And it's happy and it doesn't grow back out. One of the next questions, has weather studies been done on pain? I was awakened in stabbing pain last night and was fine all day, but at the end of the weather change from dry to very humid last night, I find that is triggered at times. It's one of those things that there have been studies. I haven't seen any that have a kind of that are statistically significant, meaning take a big enough population of people, ask them all the same questions, and is there a trigger between one or the other that shows that it's definitely that and not just random? To me, it makes a little bit of sense just because the idea of when a storm comes in, there's barometric pressure, so there's more pressure. Some people might say that their sinuses are stuffed up because of the change in pressure, or diving down in a pool, there's a change in pressure and there's pain. The same sort of thing would hold true. Now, how it affects the nerve internally, that is kind of left for someone with a little more expertise than me. Let's see. Has there been any documentation on a theory that osseointegration might confuse the brain from the osseoperception standpoint, thus resulting in a default response from the brain, that being the occurrence of pain? No, I've talked to dozens of people that have had osseointegration. One of the little benefits that they said that there was this awareness of the prosthesis being able to feel a makeshift sort of sensation, in that if I run my, let's say I have it in my arm so you can see me here. If I run my hand across something and I'm wearing a traditional prosthesis, it's like wearing a big thick shoe. So if there's 8 inches from here to here, it's like me wearing an 8-inch high heel. I could sort of feel what I'm walking on, gravel and things, but I couldn't feel the textures. Well, when it's directly attached to the bone, if I run my hand across the surface, I could feel the vibrations into the bone. So I've had people tell me they can feel where their leg or their arm is in space better because there's less play in the socket. But as far as confusing the brain, that would be kind of a really cool study to look at magnetic, doing MRI of the brain to see what part of the brain lights up when someone is walking or using an osseointegrated prosthesis. It'd actually be a great study. Has there been any suggestion for post-op acute and chronic pain post a TMR, which was done 5 years post-amputation, 2.5 years post-revision, cannot wear a prosthetic and have electrocution type pain? Well, right after surgery, it takes a little while for the nerve to grow in. Nerves only grow about 1 millimeter a day, about 1 centimeter a month. So it takes a little while for that nerve to completely grow in. Now, there's some things during surgery they can do where they stimulate the nerve and stimulate the muscle, and it kind of helps because the muscle wants to take the nerve. If they cut the nerve to this little muscle fiber, the nerve is sort of like sitting there wanting, the muscle sitting there wanting nerve. The nerve is wanting to contract something, so it wants to grow into it. But it does take a few months. Most people will tell me that about a month afterwards, they'll start feeling some twinging in the muscle. And then maybe a month and a half, 2 months, they can kind of contract and they can feel something. And then from a process, when I do, let's say a myoelectric prosthesis, and I put the little surface sensor over top of the skin onto the muscle, right about 3 months is when I start getting a useful signal that I can pick up and have the person control the prosthesis. So typical post-op care is you have the surgery, let's say it was a revision, you go, as soon as the sutures come out, you go right back into your traditional prosthesis, so that way you're functional. And then as those nerves come in, you start to visualize. You start thinking hand open, hand closed, because the more I use it, the more fibers I'm sending down and the quicker it's going to grow. And then right about 3 months is when we would start looking at switching control from maybe a dual site bicep and tricep to maybe 5 sites to have hand open and close and pronation and supination and elbow up and down. So it's kind of the old adage, like your mom said, you use it or lose it. The more you use it, the better the fibers grow in. Let's see, next question. Can you talk a little bit more about TMR versus RPNI? Yeah, so targeted muscle renovation, most of what we're doing with electrodes and prosthetics is surface. So targeted muscle renovation is picking a muscle that is close to the skin. So that way when we put a sensor on the skin, it can pick up that signal. Again, but the big thing is the pain management. Now, RPNI is taking a small donor muscle, a little tiny 1 centimeter muscle, taking the nerve, putting it into this muscle, flapping it over, and putting it deeper inside. It's an easier surgery. It's a quicker surgery. It should have the same results, targeted muscle renovation versus RPNI, because the same thing happens when I think hand contract or move my foot up, the muscle contracts, whether it's a muscle close to the skin or a muscle deep inside. The muscle close to the skin we can use for prosthetic control right now. The muscle deep inside, we're eventually going to get to where they can put electrodes in the body and pick up directly from that little muscle, which is going to be, I think as a prosthetist, kind of a game changer, because now my socket fit doesn't matter. We're just not there yet. Once you start implanting things, it becomes more difficult to do in longer FDA procedures. Let me just hit the 3 o'clock button. Let me switch back over and see if we're still live. I think we are. I'll kind of continue. I know you guys, typically they give you guys a 15-minute break to get to the next session. I'll keep running through the questions until somebody on the IT side tells me to stop. This is from a person who says, neuroma issues here right behind a bone spur. Would surgery be the only fix? No, surgery is invasive. It's a surgery. We typically try the easiest things, the less amount of negatives first. So with a bone spur, it's trying, as a process, we try to unload it, meaning put a little pocket somewhere to take weight off of that painful area. And we try everything we can to do it to try to prevent having to have a surgery. If we get to the point where we've just exhausted the options and you're not able to do the things that you want to do, you're not as active as you want to do, and we've just exhausted, whether it be prosthetic modifications or desensitizing that neuroma, then surgery is an option. It's not the one most people want to jump into right away because it is a surgery, and there's always risks with any surgery. Here's another one. Sorry, what does EMG stand for? I apologize. EMG is the electrical myographic signals. Basically, it means when you tighten a muscle, your muscle gives off a small electrical discharge. And with a surface electrode, it's a little sensor that we lay on your skin, we can pick up that signal. Think of it kind of like the smart watches or the heart rate monitors that are picking up the electrical activity in like your heart. It's the same thing, except for picking up a muscle in your arm or your leg. See another question. Does one need to be predisposed to acupuncture working for it to work? No, acupuncture works in a different way. It's my understanding, and I'm by far not an expert in acupuncture. The way it's been explained to me is that acupuncture works by stimulating different nerves. You only have a certain number of nerves going up to your brain. So when you stimulate other ones, it leaves less pathway for the pain receptors to go up. Kind of think of it like when I hit my thumb, my reaction is to hold my thumb and squeeze. And the reason for that, the reason it helps is it didn't do anything to the pain receptors. What it did is now I'm getting sensation of squeezing my thumb. So if I have a water tube and I'm putting a different color down it, squeezing, there's not as much room for the nerve impulses to go up, and that's why that helps. And that's sort of the idea with some of the acupuncture. And there's lots of other parts with acupuncture, but two different ideas with replanting the nerve in a functional muscle. Next question, how do we find out if RPNI will help? To me, it's always more information is better than none. It never hurts to get a consult from your physician, from your surgeon, and from your PM&R doctor, and if you're working with a pain management physician. I always want to find out what the different options are and what the possible benefits are and what the possible negatives are. So taking a medication might help with pain, but there might be other side effects. Having a surgery might help with the pain, but there's always that risk when you go under general anesthesia that something goes wrong or that you have an infection. So you really, with any treatment, you have to weigh the positives and the negatives and see which one really works for you. Next question. Can you have the TMR done at any time now to see if it works for my pain? Then feels like electrical shocks. Again, it has been studied in revision and in primary closure. There hasn't been enough of the studies done to really get a good distinction on how far out. And it does come down to a bit of what the type of pain is. So if it's a neuroma, that ball that grew into something, that has to be corrected from some way or another. So if you're going to go in and have a surgery to correct it, the idea is to put it into something to prevent it from coming back. Now, phantom pain is more that cortical reorganization that we don't completely understand, but people have reported that the idea of thinking tighten a muscle and a muscle actually tightening, the brain sees that as the normal. That's what it's always done. And that's where the phantom pain helps from. Now, the neuroma pain that I tap and shooting pain, it's very, very rare for a neuroma ever to reform if it's been an RPNI or targeted muscle renovation, because it's grown in and it's happy and it has no reason to grow back out. But there is always that exception, and we see less neuroma formation in the older you get, the less healthy you are, because you just don't heal as quickly. That nerve doesn't grow as well. The younger, the healthier you are, the more kind of chance there is for that nerve to kind of regrow or overgrow. And let me switch back, make sure we're still live. Yep. Let's see. Next question. Brian, how does this study been known to work for those with knee disarticulation, limb loss, or limb difference nerve block-wise. It doesn't matter really whether it's upper or lower. They're actually using it. I've seen some studies come out recently for breast reconstruction. When they go in with any surgery, if they're cutting through a nerve, that nerve wants to regrow, whether it's an ACL repair, breast reconstruction, limb loss. You cut a nerve, that nerve is disrupted and doesn't know how to regrow, and it's going to form a neuroma. Whether it's painful is kind of where that neuroma forms. So it really doesn't matter on the level. It's treating the nerve, and then hopefully treating the long term. The underlying issue is nerve, and not sort of the modalities of desensitize it or visualization. It's fix it from where the disruption is. And I think I actually made it through all the questions, which means I guess I'm going to wrap it up if they didn't cut me already. And I believe at 4 o'clock there is I think they're calling it a rapid fire Q&A. I'll be on that. I'm sure there's other people on it and can address some questions, I assume, live. Thank you for your time.